Hello there, welcome to East Surrey Hospital. My name's Carol Postlethwaite. I'm one of the senior medical registrars that works here. So I'm going to tell you a little bit about your job as the medical registrar, and I'm going to split it into the two main types of jobs that we cover. So firstly I'm going to cover our job as the acute admitting registrar. So you'll be carrying Bleep 700 and your day starts and ends more or less with a safety huddle. So you need to get to your safety huddle at 9 o'clock promptly to coordinate the jobs for not only your juniors but also for the outreach team and for the cardiology specialist nurses and everybody that helps us on the medical emergency calls. After you've allocated jobs for that, your job is to touch base with the consultants and the rest of the team on AMU to check that all of your staff are in and whether there's any special arrangements for the day, such as people turning up late or locums appearing. And in fact, if you do have locums, it's best to get to know them early and work out whether they've ever worked at the trust before or whether they need access to the Cerner system through the site managers, in which case it's best to allocate somebody to trot them down the corridor and get all of that sorted out early on. At 9 o'clock, you are the only person from the on-call team who is going to be clerking. However, don't panic. You have a couple of SHOs or housemen from the acute medical unit who are going to come and help you. Your main clerking team is not going to turn up till 12:30, and hence the need for the 12:30 huddled to welcome them back into the fold. So don't worry, you have plenty of staff. Once you're happy with the fact that your team's in and you've worked out who the consultant on call is that's going to be helping you out during the day, your job is to go down to accident emergency and start fielding the referrals. The on-call in this hospital is very busy, there's no getting away from that, but your job is essentially to be the glue that sticks everybody together and keeps everybody going. So you need to coordinate between the accident and emergency juniors, the accident emergency consultants more often than not, the registrars, but also keeping a handle, if you can, on your juniors and making sure that they're coping okay as well. Now, the thing to mention here is actually this is quite a different trust in the way that the take is organised, in that you as the acute registrar are organising the front end of the take, so you're organising all of the patients being referred to you, but actually the responsibility for post-taking or reviewing the patients, unless they're acutely unwell before they're post-taked, actually lies with the post-taking consultant. And so you don't really get to see the back end of the take much, which can feel, when you start, actually really quite threatening, that you don't really know what's going on with the take. But you do have to take a little bit of a leap of faith, and as long as you keep in touch with your juniors, then they'll tell you whether the patients are coping okay. So your main referrals either come from accident emergency or from the general practice. Now, general practice bleeps are taken during the day by other registrars, so you don't have to worry about those. The accident emergency referrals all come to you either via your bleep or whether you're pounced on when you're walking through accident emergency. What we're trying to do to try and increase the networking between acute medicine and accident emergency is for the acute medicine reg to stay in accident emergency as much as possible, so that you can make a relationship between yourself and the juniors that are on call, and then they're likely to come for you to advice so that you can actually get involved with the patients earlier rather than later, and so have a good idea of who's going to be coming into your take, and to possibly go and use the accident emergency team as a resource and review the patients with them so that they can do some of the work for you. And trust me, you're going to need lots of help and as much of help as you can take. The idea that we're trying to come to is that you don't actually clerk the patients yourself. Now, that can be very difficult because the takes are very busy and you can feel overwhelmed with the numbers of people that are in front of you. And in my own experience, it's almost impossible not to clerk patients. However, what I would encourage you to try and do, if you can, is to see people who you think can get discharged early on and to use your accident emergency SHOs as your resource to do that. And the other people that it's very hard to ignore are the people in resus. And so you may spend a fair bit of time in resus seeing your patients as well. Again, from personal experience, I would, if you can, take one of your SHOs with you and get them to do as much of the work as possible, because otherwise you can end up spending far longer clerking a patient whilst you're also fielding the multiple bleeps that you're getting from other people, and that actually can be less efficient than you think it's going to be. I find the job as a 700 bleep incredibly enjoyable. One of the things that it's great about is because it's the constant challenge and the constant throughput of patients, and you're always having to be on your A game, which is why it can be quite exhausting as well, and it's very easy to get to the shift having forgotten to drink anything or eat anything. The great thing is that actually the accident emergency nurses and juniors are very good at spotting a flagging registrar and will commonly grab you, force a cup of tea down you and send you off to the sandwich shop to get a sandwich. So that's the kind of experience that you'll get working at Redhill. Your job ends at 9 o'clock, where you get back to the AMU office and you start reviewing all of the patients with your whole take team and then the night team coming on. We've done quite a lot of work to improve the handover process at Redhill, and now everybody is sat in one office and everybody's listening, and you are running that meeting. What's really important is to go through each of the patients and just check that there's nothing outstanding that needs addressing overnight, and you will also try and coordinate the ward doctors that are come to hand over their jobs as well. And then hopefully by 9:30 you'll all be finished. The take team for the night will be fully appraised of what's happened, and you'll be able to go home having felt that you've done a grand job. So the night shifts, you are a mixture of both 700, so the acute take, and the ward cover bleep. So that sounds kind of busy, and it is. But in reality, the bulk of the ward cover job is done for you by your house officer. Now, the most important thing I can tell you about this point is please make sure your house officer is coping, because we are very busy here, and it's really important to try and touch base with them at the very least once a night. And so what we're trying to do is institute a huddle at 2 o'clock in the morning, and a bleep will go out to remind you that there is a huddle about to start. That way you can check that your house officer's not crying in a corner and that they've eaten something, and I think that's really important. It also gives you a chance to catch up with your 2 SHOs who have been beavering away clerking all of your patients, and you can check they're fine too. It will come as no surprise that throughout the night you'll be asked to go and see people on the wards to support your team, as well as see the take patients that you're being referred from accident and emergency. And the great thing about this trust is that you've got very experienced ITU nurses to be there as your backup as well, as the critical care outreach team. And in addition to that, you often have some very experienced clinical site practitioners as well that will also be helping out with seeing difficult to manage patients and helping advise the nurses who are running their wards at night. So the nights, I find, actually in some ways more enjoyable than the days, although don't tell the consultants that, because actually you are finally in control of your take again. You're not only being able to see the patients, you're reviewing the patients, and you feel like you're doing the full job as a registrar. And so in that way, in some ways, nights are even better than days. Your night shift will end as your day shift started, in the huddle where you hand over your bleep and hand over any concerns that you've got about patients on the wards to the day team that take over. And then by 9:30 you're free to go off and find your bed and have a nice restful sleep. So there's a meeting that you have to go to as a night reg called the Hospital at Night meeting. Now this at the moment happens at 9:30, but it's likely to change time a little bit later to happen a little later in the evening. Now the reason for this meeting is to get information from the medical reg, from the intensive care registrar, from the surgical SHO on call, and from the clinical outreach sisters to see who is sick on the wards, who's going to need extra support, and also for the site manager to check that everybody's actually present and well, and so that we can find out the bed state. It doesn't usually take very long, and it's usually sort of quarter of an hour. The biggest problem that you're going to have as a medical registrar is trying to field all of the referrals that accident emergency are trying to make to you over both your handover and the hospital at night meeting, but they're often quite good if you explain that you're in a meeting and you can go and pick it up with them later. I'm now going to talk about the ward cover shift, and the ward cover shift is very different between the week and the weekend. So I'll start with the week. So during the week, you on the 251 ward cover shift don't really have very much in terms to do practically during the day between 9 and 5, other than to go to the emergency calls and the arrest calls outside of accident and emergency and the acute medical unit. So you'll cover the rest of the hospital. There's quite a lot of the rest of the hospital, and that includes also the surgical and orthopaedic wards as well, and all of the little nooks and crannies that you never really knew existed. So one thing I would suggest is that you spend a fair bit of time wandering around the hospital, getting to grips with where stuff is, because if you're going to have to run there fast, then you need to know where things are. And one big tip is to find one of the big hospital maps on the walls, and before you run somewhere, check it's where you think it was, just so that you don't run down the wrong end of the hospital. So at 5 o'clock, your ward cover bleep will now start bleeping quite incessantly by calls coming in from the out-of-hours GPs who are wanting to refer patients into the take, either for that night or for the next morning. So your job is to update the patient tracker system that the juniors have mentioned, and to be quite clear about when the patient's coming in and to give a little bit of background about what's wrong with the patient. It's really the only way that we have of knowing when patients are coming in, where and what's expected from them. So it's really vital that you put a reasonable amount of information on there. Your job then really is to field any queries that your juniors have or the nurses have from the rest of the wards, and go and help patch up any of the acutely deteriorating patients. And it's a very variable shift. It can be very busy. It can be actually really quite reasonable. What's certain is you'll usually spend a fair amount of time going down to see the respiratory wards, who often deteriorate quite quickly. So that's it for the ward cover bleep. That finishes at 9 at the huddle, back in the huddle, like the day shift started. At the weekends, it starts at 9 o'clock, again in handover in the safety huddle. But right from the set-off, you're going to be dealing with different things. So often on a Saturday or a Sunday, you can be asked to support the TIA clinic, which runs in the mornings. I've not actually had to go and support that yet, so it can be quite quiet, but occasionally you're needed to support the TIA clinic. After that, as the juniors have to do at a weekend as well, you also have a long list of patients to go and review over the weekend who are anticipated to deteriorate, or there are jobs that are at a registrar level that need addressing. Now, the thing I'd say about that is that as registrars, it's our responsibility to make sure our juniors during the week are putting appropriate patients on that list. And what I'm keen for us all to do is, particularly on a Friday before the weekend, ensure that your juniors pass by all of the jobs that are being put on PTS for the weekend through you, and you should be approving the things that go on that list to make sure that the weekend team, and that's yourself included, aren't being asked to see things that should have been done during the week or are not necessary, because you are going to be busy. The rest of your weekend is going to be spent seeing those expected patients, deteriorating patients at MET calls, or being asked to see, sometimes you are asked to see the outlier patients that the consultants aren't able to go and see and review themselves. But it's a very busy shift, and you will spend a lot of time running up and down the hospital, and your step count will be very high, which will be great for your overall fitness. I would suggest that you bring a packed lunch with you and have it in a pivotal place in the middle of the hospital somewhere, so that you can pick at it as you go along, because otherwise it could be a bit tricky. Generally, there is food and drink available in the trust. Most of the shifts, we have some little machines that have some not terribly healthy food, but it's good food to keep you going if you have, by accident, forgotten to bring stuff with you. So generally, that's all very doable. I thoroughly enjoy working at East Surrey, so much so that I'm actually planning to spend even more years here, and may even try and get a consultant job here. So if I like it, then the chances are you're going to like it too. In terms of asking for help out of hours, the consultants are, on the whole, very amenable to being called out of hours. The big piece of advice is to check who's on call. If you can, and it isn't always possible, try and touch base with them if they're still in the hospital at the end of the day shift. If you're on a day shift, do try and make sure you know who's supposed to be covering which bits of the on-call, so that if you have an opportunity to review patients that you've taked with them, then that can accumulate into one of your ACATs. Sometimes it's difficult to know who's the GIM consultant on call, and so we now have a board which is in the acute medical unit which has all of these details on it, just in case you're unclear. If you need the on-call consultant out of hours, then you need to contact them via switchboard. Switchboard will have the contact details of all the consultants that you need on their Rolodex, and they will contact them for you. Sometimes the consultants will approach you and give you alternative numbers should there be special circumstances. The other time that you may actually need to contact people outside of the trust are for patients who need neurosurgical advice. So often you may need to ring your neurosurgical friendly reg at St George's Hospital, which is our local area, the renal reg, which is at St Helier. We have a gastro consultant on call for acute GI bleeds who you need to contact via switchboard, and obviously your GIM consultant on call, who again is via switchboard. The one further person sometimes that you need to ring is for the Medica service, which is our out-of-hours radiology service, which again is through switchboard, and who you have to request out-of-hours CT scans for CTPAs or urgent CT chest abdo-pelvises and the like. The cardiologists are there for if you need pacing out of hours and you're unable to manage the patient with external pacing, then our consultants will always come in and assess the patient to see whether they need temporary pacing, and if so, put in the pacing wire themselves. So please don't panic, you don't need to do that. The other thing that you're able to do is call them for advice, should you need to as well. And if you don't fancy calling them for advice, then your nearest cardiology centre is St George's again, so you can talk to the registrar on call there. The other people to talk to potentially are the haematologists if you need help over reversal of clotting, or reversal of warfarin or apixaban or any of the other abans, and to give them a chat as well. And them and the microbiologists actually are incredibly good resources should you need them in the middle of the night. I think many of them would probably expect you to have had a chat with your own GIM consultant before you contact them, just to make sure that it was appropriate. But I'm sure you'll work that out for yourselves. So anyway, welcome to East Surrey Hospital. We're all looking very much to meeting you all, and I'm sure you're going to have a fantastic time here.